Welcome. I'm Leslie Canham.
I'm Mary Gavoni.
I'm Linda Harvey.
I'm Olivia Wan, and together we are the Compliance Divas.
Welcome to this episode of the Compliance Divas podcast. My name is Linda Harvey, and I'm happy to be serving as moderator of this episode titled, Uh-oh, I Just Stuck Myself. The Compliance Divas bring clarity and simplicity by navigating regulatory compliance to keep you on course. We invite you to subscribe to the Compliance Divas podcast through your favorite podcast channel or on our website, thecompliancedivas.com. And as always, the resources that we mentioned during our podcast can be found on the compliancedivas.com website. In addition, you're also welcome to submit questions to support@thecompliancedivas.com. So listeners, have you ever uttered the words, uh-oh, I stuck myself, or something similar during your career in dentistry? Occupational exposure to bloodborne pathogens from needle sticks and other sharps injuries is definitely a serious problem. Sharps injuries are primarily associated with occupational transmission of hepatitis B, hepatitis C, and HIV. However, Sharps injuries have been implicated in the transmission of more than 20 other pathogens. Now, you may already be aware that there is a specific protocol or process that you and your employer must follow if you have an occupational exposure. So today, my fellow divas and I will be discussing that protocol in just a minute. Please remember, an occupational exposure is not limited to a stick with a used needle or a cut from a contaminated instrument. An occupational exposure can also occur from a splash to the eye or other mucous membranes such as the nose or mouth if you are not wearing the proper PPE. This specific protocol for an occupational exposure can also be found in OSHA's bloodborne pathogen standard. And specifically, the bloodborne pathogen standard requires you to have a copy of that OSHA standard on hand. So if you'd like to read along with us, you'll find this information that we'll be discussing today in section 1910.1030, subparagraph F3, titled Post-Exposure Evaluation and Follow-Up. And we'll always have information available on our website as well. In addition, you must also follow the U.S. Public Health Service guidelines for the management of occupational exposures to immunodeficiency, the human immunodeficiency virus, and recommendations for the post-exposure prophylaxis. While time doesn't permit us to discuss this medical management of exposures in depth today, we will make these resources available on the website. And I would also refer you to our podcast on managing Sharps disposals if you have not had a chance to listen into that one. Now, as we begin our discussion, let's bear in mind there are three actors, if you will, in any exposure incident: you as the injured employee, your employer, and the patient. So Leslie, can I ask you to please lead us off with some insights about the employee's obligation when an exposure occurs, and maybe tell us a little bit about some differences between contaminated and non-contaminated injuries?
Well, certainly, Linda. You know, when an exposure incident occurs, there's two things that have to take place. First of all, immediate first aid to the exposure site, because as the employee, you certainly don't want to be infected with something that you could avoid by simply providing first aid. Then secondly, we need to comply with OSHA's bloodborne pathogen standard, and we want to expedite medical treatment to the exposed employee and, of course, follow all the proper paperwork. So when someone has an exposure incident, it's important not to keep it a secret. In my experience, there have been reports that an injury occurred, either it was a Sharps injury or a splash to the eyes, nose, or mouth, and the employee was embarrassed to report that to their employer because they didn't want to seem like they were accident prone or that they weren't competent in what they were doing. They were also afraid that they might get fired for having an accident. And it seems to me that the better way to approach this would be to look at what's the fastest way that I could prevent infection transmission from occurring. So explaining that to any employees that join a dental practice, that reporting to the employer or supervisor or even a coworker immediately upon the occurrence of an injury or an accident that produces bloodborne pathogen exposure is extremely important, and it's part of our work policies. We're not going to fire you for reporting that you had an accident. But if you do have an accident and you hide it or you keep it a secret, that does change how we feel about keeping you in our practice. We don't want you to get hurt and feel that you can't share that information with us. So we want to make sure that employees also feel comfortable reporting that accident or injury. So in at least initial training and in annual training, it's very important for whoever's in charge of OSHA to convey that message. Now, when I think back to the days that I was working as a dental assistant, if I was working chair side, I'm going to just put a scenario together. If I got poked with an instrument, I would probably say, ouch, or maybe something worse, hopefully not something worse, but I don't think it would be a big secret. However, if I was working in the sterilization room and had an accident, nobody would probably hear me say ouch. And so the most important thing is for me to report immediately. First aid is first, but then report immediately to someone that I had an accident so that the next steps could be taken to expedite not only first aid, but the steps of seeking the attention of a medical evaluator to make sure that not only am I going to be have some medical guidance if I was exposed to bloodborne pathogens. But as you mentioned, Linda, this not only is bloodborne pathogen exposure, it could be I could have been exposed to my own bacteria on my own skin that reached my bloodstream. And so a medical evaluator would be able to help me with making sure that I didn't get an infection by providing with the proper post-exposure prophylaxis.
Thank you, Leslie. I loved how you highlighted those immediate steps for our listeners. The first aid, that's the first thing we need to do is stop to take care of the first aid. And I realized
I also wanted to mention the difference between contaminated instruments and non-contaminated instruments. Sometimes we're opening up an autoclave bag or a cassette and we might get poked with a perfectly sterile instrument. So that would not be considered an exposure incident. It would certainly be a Sharps injury and first aid would be warranted, maybe even beyond first aid if it was a severe cut that might require sutures, for example. So if you think the instrument is contaminated, or if you don't know for sure if perhaps that instrument commingled with other instruments that were contaminated, I would err on the side of caution and call it a contaminated instrument. But if you know for sure that the instrument was sterile, then first aid would be warranted, but we wouldn't need to go through the other steps. And of course, certainly we'd want to let our employer or supervisor know because it was an injury that occurred. And we want to make sure that it's not only investigated, but we share that kind of injury can happen so others don't experience that as well in our practice.
Well, thank you, Leslie. I loved how you highlighted 3 key points. One was the immediate steps that injured worker needs to take, and that's the first aid and notifying their supervisor. And we know in a small dental practice, the supervisor may primarily be the doctor, and doctors, you may be with a patient and not be able to be interrupted right away. So you have to work through this in advance in your office to know what the protocol and how we're going to notify. And second was not to be embarrassed or afraid to share when we have an injury, when something happens. I know it's often we feel like we're something to blame or we did something wrong, but let's face it, human error occurs all the time. Life is not perfect, and it just may turn out to be an opportunity for improvement that you just identified by having this error. There could be a way that can be improved and look at Sharps more safely or differently. And then lastly, Leslie, you talked about just the contaminated versus non-contaminated Sharps injuries. And that's really important to tease those two apart as much as possible, especially if you know that you're opening a sterile package of instruments and you stick yourself at that point versus one that may be questionable. So anytime it's questionable, it is better, and I totally agree with you, to look at it as if it's contaminated and let that medical professional make that next judgment call by going for that evaluation. So then moving along to the next actor in this group, we have the employer and the employer's obligation. Olivia, can I ask you to share with us some obligations from the doctor's perspective under OSHA and CDC, And where should an employee actually be sent when they have an injury?
Sure. Thank you, Linda. One of the important points to remember is that the employer is responsible for any of the cost associated to post-exposure management. So we suggest that dental practices arrange in advance a medical clinic or occupational clinic that would handle exposure incidents that we've discussed. So we should not wait last minute to try to find a clinic to handle the incident. And when you're designating a clinic, go ahead and set up an account. The account should show that the dental practice is the account responsible for the fee associated to providing care for the employee or source individual testing of the source patient. So that's an important point, that these costs are out of pocket to the dental practice, not to the individual employee. Also, employees do not use their personal health insurance for these expenses. If you look at a health insurance claim form, there's a box to indicate whether this is a work-related incident or not. When it's reported as work-related, this would trigger a workers' comp claim. Now, granted, it may not be worth filing on workers' comp, depending on the costs associated to that. But what I want to emphasize is that the employer is responsible for those costs. And also, as a side note, that this is a medical emergency. So the employee should not be put off to wait to the end of the day. So we need to have these arrangements made ahead of time. So for example, if hygienist has an incident at 9 a.m., they should never, ever be told to wait until the end of the day when they've completed their patients to follow up on this. I've had this happen in an office, and OSHA did follow through, because they do consider sharps injuries, such as what we're talking about, or exposure incidents, to place the employee at imminent danger. And trust me, they would follow up on these matters. So just to conclude, the employer is responsible for these costs, so they'll need to designate a clinic ahead of time. So Linda, I hope that helps our listeners.
It absolutely does, Olivia. Thank you so much, because like you said, we've got to plan in advance, and nobody plans for an injury, but we know we're supposed to be planning. We should be planning here. I'm in the South. We plan for hurricanes. We get prepared. In the North and other parts of our country, there's other types of disasters and things that folks plan for. So let's be proactive in our practice and plan for this type of scenario as well, by one, proactively identifying that medically approved facility where you should be sending team members and setting up an account. I've had offices tell me in the past that they go to send a team member someplace and they've had a turnover of staff at that office or that facility, and nobody knows who anybody is. So that's a challenge. So I think as much as we can be proactive with that, that's very important. And lastly, I think that you shared a perfect example of how OSHA would look at this. And I know that all of us divas have numerous stories about clients that we've worked with as well. And I'm thinking of one famous story I actually read on the internet, probably close to 10 years ago now, but it just drives the point home that this is considered a medical emergency and needs to be addressed in a very timely fashion. So thank you very much, Olivia. Mary, let's turn to you and let's talk about the third person in our group here, in our play, and our actors, and that's the source patient. So could you share with us a little bit about what the bloodborne pathogen standard says about the source patient, and how do we manage this individual?
Absolutely. And I so agree with what Olivia said about making sure that you have a plan and make sure you're working with a medical facility that can help you manage these incidents so that you know what is the right thing to do. There are some cases where a medical professional might say that the risk is very low and they may not even recommend testing, but you still have to make sure that you at least approach the the source patient, if you know who the source patient is, the bloodborne pathogen standard says that you must identify and document the source individual unless you can't establish who it is. So an example that I use when I'm teaching is if you have a group of instruments that are all in the ultrasonic being cleaned, and they're from many different patients, if somebody pokes themselves with an instrument that's with that group of instruments, they don't know who the potential source patient is if there is an exposure. And OSHA doesn't require you to go and contact every single patient that was there during that time, that whose instruments may have been in that ultrasonic. But if it happens at chairside, you absolutely can identify who the source individual is. So OSHA says that the individual's blood should be tested as soon as feasible, because what you want to know immediately is if that person is HIV positive. Because if they are HIV positive, then it's likely that the healthcare professional may recommend a post-exposure drug protocol for that patient to help, or the employee to fight off an infection. So we get the patient tested as soon as possible. If we are required by our state to get their consent, then we need to do that. I always recommend that the patient go to the same facility as the employee goes for testing, for having their blood drawn. And then if that person does test positive for hepatitis B, hepatitis C, or HIV, then there are different protocols for each of those individual infections. But if you already know from the patient's medical history that they're HIV positive, or they are a carrier for hepatitis B or hepatitis C, then you do not need necessarily to test the source patient unless the medical facility recommends it. They may, if they're HIV positive, they may recommend testing the patient to know what their viral load is at that point. So you have to really understand what's going on, and keep in mind that when the bloodborne pathogen standard was written, we still weren't identifying hepatitis C as its own entity. It was diagnosed as non-A, non-B hepatitis because we still didn't have the technology to test for it. So the bloodborne pathogen standard says hepatitis B, HIV, but hepatitis C is also included in that. The other thing to remember is that if you have an exposure, you're the dental assistant, you're the hygienist, you're the doctor, and you cut yourself with a bloody scalpel blade or a bloody scaler, that does not mean that you're going to show up HIV positive immediately. It's only if you maybe had a previous exposure that you would test positive for. It's only if you would test positive for antibodies or antigen from a previous exposure. So the reason that you're tested at the time of an exposure as an employee is as a baseline. And then the CDC recommendation is that you're tested again at 6 weeks, 12 weeks, and 6 months, because it may take that amount of time for you to show up as HIV positive. So I think, Linda, this might be a good time just to have a quick review of what type of tests there are available specifically for HIV. And there's 3 types of tests available. The first one, which is not one that's used for a lot of dental exposures, because it's, first of all, it's a more expensive test, but we don't have as high a risk of exposures as they do in the medical arena. So this is called a NAT, or a nucleic acid test. And it's a blood test. So you're drawing blood from a vein, not from a finger prick. And it can tell you whether the person, could be the source patient or it could be the employee, is HIV positive, and or how much virus is present in the blood. So it's a viral load test. And it's, again, not something that's done routinely, although it may be done as a follow-up from an antigen antibody test, which could be from drawing blood or from a finger prick, or an antibody test, which could be either a finger prick or a saliva test. There are many not many. There is an over-the-counter saliva test that's available. And that may be something that's probably more applicable, and Divas, you can weigh in on this, might be more applicable for your patient, your source patient, than for the employee. So the nucleic acid test is the most comprehensive. It's sometimes done as a follow-up to an antigen antibody test and or an antibody test. So clarification on what's the difference between antigen and antibody. An antibody we're more familiar with. They're produced when your immune system has kicked in because you've been exposed to a virus like HIV. That's not going to happen immediately if you have an exposure incident. An antigen is something, virus that causes your immune system to kick in. So an antigen test is something that may be a better predictor of whether you had an exposure than an antibody test. So although we can rely on some in-office, over-the-counter saliva tests, or you ask for rapid testing in your facility, in many cases, if it's considered to be a significant exposure, then the nucleic acid test may be done as a follow-up to that.
Thank you, Mary. What great information. And I'm going to ask our listeners to consider going back and re-listening to your thoughts and comments on the different types of testing that are available, because that's so rich, and it's also very scientific, that they can really absorb that information and know what type of testing they may need to ask for or to have.
And we will have that resource available from the CDC that I was drawing information from, so that our listeners can download that and read that information as well.
Perfect. And they can also download it and put it into their post-exposure written plan. So perfect, Mary. Thank you. You made a point that I'd like to just comment on as well, and that was about being tested as soon as feasible for the source patient. And in order for that to happen, that means that an employee must acknowledge that there was an incident or that there was an injury. So that underscores again the importance of not waiting, say on a Thursday afternoon, if an incident happens, going home, thinking about it over a long weekend, coming back Monday morning, and then finally telling your doctor. It just doesn't work well, because now the further out we wait, the less likely we are to have the patient to give permission. And I think you may have mentioned, Mary, that by law, we have to ask that source patient to be tested. The patient can decline that, but I typically say, let's use our best customer service skills like we do in our marketing side of the house, and engage that patient to help us to be compliant. And so we want to have that patient agree to be tested as soon as possible.
Well, in addition to that, and I didn't mention earlier, that if you find that your patient is HIV positive, then and the exposure is considered to be significant enough that a medical professional recommends that post-exposure protocol medication, it's most effective within 2 hours of the incident, but it can be effective up to 72 hours. So there's a window of time. So if you don't report it and let your employer know it and avail yourself of medical professional services, then you might be preventing or not allowing yourself to have the best medical care to prevent you from becoming HIV positive. So you're hurting yourself more than anything else.
Perfect. And Mary, I'd like to piggyback off that and remind our listeners, with so much more sedation dentistry being provided these days, that we cannot obtain a legal informed consent from a patient who's been sedated. So that would be one scenario in which we cannot get the patient to go get tested that same day or right after the appointment. But certainly, as the patient is being discharged and they're recovering from the anesthesia, then you're talking to whoever's going to be driving them home. If it's somebody close and known to the practice, like say a spouse or a child or a parent, then certainly you can have a confidential conversation and let them know you'll be calling them tomorrow to manage this and try to get them on board early.
And some practices, oral surgery practices primarily, will ask for that consent ahead of time, that if during the procedure we have an exposure, you consent or not, you consent to us, drawing blood, or you consent to be tested for HIV.
Yeah, perfect. Thank you very much. That's a great reminder. So Leslie, can I ask you to help kind of bring our conversations, kind of back around and as we get ready to wrap up the podcast, and talk about some information that has to be provided to that healthcare professional, and as well as the medical record keeping. What does OSHA have to say about that?
Certainly. And it's a good idea to prepare these records in advance. We want to make sure that we have a description of the exposed employee's duties as they relate to the accident. OSHA wants the bloody details to be documented. So, what type of exposure, the routes of the exposure, circumstances under which the exposure occurred. And your OSHA manual will likely have a form that you can use that will ask all of these questions. So these need to be filled in, and that document would go with the exposed employee to the healthcare provider, along with any medical records relevant to the appropriate treatment of the employee, including whether the employee has been vaccinated for hepatitis B and has immunity. That's one of the bigger concerns. I think that at the healthcare facility, they're more concerned about hepatitis B status and worried that infection might occur for an unvaccinated individual than they are over HIV. And also, it might seem odd, but a copy of the bloodborne pathogen standard is supposed to accompany the exposed employee when they go to the healthcare provider. Not that I think anybody at a hospital or an occupational center would read the bloodborne pathogen standard, but it does give the healthcare provider who is evaluating the rules of the game, what OSHA expects and what time frame they expect. So all of these things could be gathered in advance of an exposure incident, and that way it saves a lot of time. As Mary mentioned, there's a window, and of course, there's anxiety that would build up for the employee who's been exposed. So the more you can prepare these documents in advance, the better. Now, post exposure incident, there is some documentation that is required on behalf of the employer, and that would include that the employer is going to receive what's called a written opinion from the healthcare provider who evaluated the employee, is going to give a copy of that written opinion to the employee, which does not have a diagnosis. It simply states that the employee has been seen, evaluated, and has been advised about further testing and treatment. And then we also want to make sure that employers absolutely must document this incident in the employee's medical record keeping form. And in some states, if the incident involved the Sharps, there might be a Sharps injury log, and you can check with your state OSHA plan to see if that applies to you. I know it does apply in California. I'm going to be providing a exposure incident protocol checklist that has all of the steps that are related from the time someone says ouch to the time that they walk out the door to what the employer has to do post-exposure with record keeping form to make it easier for our listeners.
Thank you, Leslie. You did a great job of kind of bringing it all home and wrapping up another important component. And I didn't mention this as being sort of the fourth player, if we can use the documentation in a form of a persona, and that's documenting the important components that's required by OSHA. But I can't help but bring just a little bit of levity to our conversation and do a play on words from what you said. And you were talking about bloody incidents, and it just popped into my mind that we just need to be sure to document the bloody incident. So I couldn't resist that. So with that being said, we talked about so many important components of how to handle an exposure in your practice, including delineating when it's a contaminated instrument versus a non, the important roles of team members, doctors, and the patients, source patient in this role. We'll have some very valuable links and resources, including Leslie's checklist. So thank you very much, Leslie, for your generosity in offering that checklist. And as part of the links that we'll be posting, you will find the post-exposure prophylactics hotline number. So if you want to document that and download this information and assemble that in addition to your written plan and your practice. So 3 last points that as we wrap up. Don't forget the immediate steps, the first aid, notifying your supervisor or your employer, and seeking care. Have your written plan and proactively research, as Olivia mentioned, what facility you're going to use, have an account set up, know where you're going to go. And third, if you're not sure about that, then I would recommend calling your workers' compensation insurance carrier for guidance in that direction. So thank you for joining us with today's episode. This is the Compliance Divas. We bring clarity and simplicity to compliance by navigating regulatory compliance to keep you on course. Please subscribe to our podcast through your favorite podcast channel or on our website, thecompliancedivas.com. And don't forget, the resources we mentioned today can be found on the compliancedivas.com website. And we invite your questions at support@thecompliancedivas.com. Thank you for joining us.